I'm Dr. Alan Ward, and this is a video of me performing an endoscopic carpal tunnel release on a patient's left wrist. Our incision is a transverse incision just parallel to the transverse wrist crease. Our incision is about 2 centimeters in length. Here we're dissecting down to subcutaneous tissue, spreading carefully, and we dissect down to the transverse carpal ligament, which is the band of tissue that is squeezing the median nerve. I'm inserting the freer elevator distally beneath the transverse carpal ligament, and we dissect away tissue that is attached to the undersurface of the transverse carpal ligament to improve our view. I'm palpating the very end of the transverse carpal ligament. We make a mark at the very end of the ligament, which shows us the depth to which we place the cannula. We then insert the small dilator, which opens up the carpal canal, allowing us more space to insert the slotted cannula. This is the slotted cannula, which we introduce into the carpal canal beneath the transverse carpal ligament. At this point, the median nerve is deep to our cannula. The transverse carpal ligament is superficial to the cannula. Next, we introduce the scope into the cannula, and the view on the left is the view that we see through the endoscope. This is the transverse carpal ligament. As you see on the left, it has a washboard appearance that is seen, and at the very end of the cannula, you see the needle, which is placed at the end point of the transverse carpal ligament. This tells us when to stop cutting with the knife. This is the endoscopic knife, which is inserted under direct endoscopic visualization. We are transecting the transverse carpal ligament, advancing our scope in conjunction with the knife from the proximal to distal. As we advance the knife, we see that the ligament will retract, and our ideal scenario is to see the ligament retract in a trapezoidal configuration. As you see here, we're having to make a second pass at the mid-portion of the ligament to complete the division of these transverse fibers of the transverse carpal ligament, which is the ligament that is squeezing the median nerve. At the very end of the ligament, the transverse carpal ligament gets thinner and is more easily transected. Once we complete the division of the ligament, we can remove the needle and we rotate the cannula, and you see the median nerve, which is that white structure at 10 o'clock as the cannula is rotated in the screen on the left. There's the cut edge of the ligament that you see that has retracted about the width of the cannula, which is about 3 millimeters. And we're seeing that the cannula is very easily rotated at this point as there's more space in the carpal canal for its contents, which includes the median nerve. Several little fibers that remain can be transected under direct endoscopic visualization. We at this point dissect more proximally. We're cutting beneath the distal antebrachial fascia, which is tissue that can compress the median nerve above our incision level. We're sneaking under that fascia with the freer elevator and with blunt dissection. We then pass the small dilator beneath that distal antebrachial fascia, again to open up the space for the cannula. We then insert the slotted cannula beneath the antebrachial fascia, advancing it proximally several centimeters. We'll dry the field, remove the obturator, and place the endoscope into the slotted portion of the cannula once we've dried it with the Q-tips. The scope is inserted into the cannula, advancing it proximally, and you can see on the view to the left, the endoscopic view shows the distal antebrachial fascia clearly. We will then divide it with the endoscopic knife under direct visualization using the scope. We advance the knife proximally to divide these fibers, much like we advanced the knife and divided the transverse carpal ligament fibers distally in the previous segment. Once again, these fibers are sometimes divided with a second pass of the knife. We rotate the cannula to visualize the median nerve, which you can see as this structure seen at 3 o'clock. The white, sort of an off-white tubular structure, and it looks as if it's been well decompressed. The cannula rotates very smoothly. We close the skin with a subcuticular suture, which is usually absorbable, which leaves a very cosmetic closure with a skin incision that is parallel to the existing wrist creases. We apply a sterile adhesive to the skin to increase the adhesion of our sterile tapes, which are applied to protect the wound in the postoperative period. We apply a sterile dressing. Over that, we apply a fiberglass short arm splint. Over that, we wrap a bias stockinette, which is the light tan material. The thumb and fingers are left free. The dressing is removed on the 4th postoperative day to start an active range of motion protocol.